great, but there's sort of a reductionist view of medications that if you increase these happy chemicals, everyone's going to be fine. And our medications sort of work in spite of the fact we don't know exactly how they're working, but they work and they're safe. And even from the time that Dr. Drummond and I trained, we have more options than ever before, but we need even more options. We're understanding better how they work at other levels. The way we image the brain has led to direct outcomes in terms of new treatments for the brain. Any guess as to what might be happening here? I hear whisperings of ECT. So does everyone know what ECT is? Anyone in the audience want to say what it stands for?
Electroconvulsive therapy.
Electroconvulsive therapy. That's shock therapy. Anyone surprised we still do that? Go back to Cuckoo's Nest. That's not how we do it. That's not what it looks like. It's a very controlled medical procedure with anesthesia. And this is something that we do at MUSC, that we take referrals from other folks because it requires a highly trained, not just a psychiatrist. We can train psychiatrists to do this, but you have to have the rest of the personnel to be able to know how the anesthesia works and how it all interacts. The success rate with ECT is about 90% to treat refractory depression. A lot of people don't want to do it because they've seen it in the movies and say, I don't want that to happen to me. I don't want to be that person. So again, we have to break down these barriers to treatment. This is me in my much younger days, but actually teaching medical students how to do things like ECT and how to assess a patient, prepare them for ECT and treatment. So just an important part of what we do is training the next generation. Any guess what this is trying to indicate here?
TMS.
Anyone heard of TMS before? Transcranial magnetic stimulation. Dr. George at MUSC has pioneered this treatment. This is literally, and so this sounds science fiction, but this is creating an electromagnetic field that stimulates a certain part of the brain that very effectively treats depression. So again, I can explain the science and have everyone here go, okay, that sounds legitimate, but you just say this to the average person, like, really? Treating depression with a magnet? What's that all about? So we have to explain, understand, and help people understand what we're doing. We're not putting biscuits in people's brains. This is just showing you the size of a vagal nerve stimulator that can be implanted and used to treat things like refractory anxiety and depression as well. So a lot of really advanced techniques. Why don't more people get ECT, TMS, get things like vagal nerve stimulation? Nobody's paying for it. The insurance companies go, well, yeah, there's data to support it, but most people don't need that, and you're not going to get it. If you needed a hip replacement, they wouldn't say that. Another thing we need help with, and we still do therapy. Again, probably not as much for the patients that Dr. Drummond and I are treating. They're not laying on couches talking about, their moms. We're talking about either in the hospital or outside the hospital doing very regimented cognitive, sometimes behavioral therapy that's really very sort of protocol driven and very evidence based. And this is what we're dealing with. And I might let Dr. Drummond pick up a little bit on this and sort of transition into where we go from here. As big a problem as we have, so how many patients in your ED right now waiting for a bed?
Right now there's like 14.
Okay, so that's a good day. Mm-hmm. Yeah, same with us, so not too bad. We also have folks scattered throughout the rest of the hospital who came in for cardiac procedures, hip replacements, for transplants, who are dealing with depression, anxiety, mania, schizophrenia, that need help, and then once their medical condition is stabilized, they may need more treatment with us too. As much as we struggle with that, we're lucky here. We have probably more resources in Charleston County than a lot of other areas in the state, and we need a lot more. So when I get calls from outlying emergency departments scattered throughout the state, there's a real sense of desperation in their voice when they say, I need help with this patient. I know you guys are full. I just wanted to see if there's anything else I can do, any way I can get them into your facility. And then I usually hesitate but need to know and ask, how long has the patient been there? Well, 2 weeks. 2 weeks sitting in an ER, not getting, the care they really need. So we're need more resources here, but fairly lucky.
Right, so Trident had got, when I first started here, before we started to add on resources, though, Trident was not, we would have people stay 1, 2 weeks. Well, I'm talking about
Yeah.
because our average was almost like 5 days of an average wait. It was
So-
bad, it had gotten really bad here. That's when we realized our system wasn't really.
It was several days, yeah.
It was
was-
several days, which we
3
managed
was
to get
the
down.
average, so 5 to 7 was not atypical of a wait for it.
And this is someone in a psychiatric life crisis, right? So, and they're sitting, just sitting, sometimes getting some active treatment like we try to do here, and sometimes not much because we can't provide what they actually need. So we managed to bring that down with some additional resources, including staffing and beds here at Trident, to more like a 1-day average, which is pretty good because some of these people have particular needs that take longer. But we've drilled it down quite a bit by being very aggressive on what we can do with some success. But it was